on LinkedIn, it takes a bit longer, but on YouTube, it's very quick. Okay, I think we should be good to go. Good morning, good afternoon, everyone, and welcome to the special thought leadership panel co-hosted by EthAum and Syauctus AI. Today's topic is one that resonates deeply across hospital boardrooms on both sides of the Atlantic, from burnout to breakthroughs, scaling revenue and efficiency with supervised AI in hospitals. This is Pankaj Gupta from EthAum and Partners. We are a deep tech revenue scaler and fund based in Singapore with approximately 120 startups in our portfolio from different parts of the world, sectors, and stages. Clinician burnout is real. Revenue leakage is costly. Administrative overload is crushing hospitals. What if supervised AI, trained and overseen by clinicians, could reclaim time, strengthen documentation, slash denials, and boost margins without compromising care? And in order to answer all these questions and share insights, we have an outstanding panel of leaders from leading hospital groups in the USA and UK who are living through this transformation right now, who are adopting this transformation right now. I would request Nikesh to go first and introduce himself. Nikesh, please.
Thank you, Pankaj. Good afternoon, good morning, good evening, everyone. So my name is Nikesh Davda. I'm a Chief Financial Officer by background. Just to give you a little bit of insight, I've been a CFO in a number of organizations, including oil and gas, hospitality, and more recently in the past 10 years in private healthcare organizations in the UK, US, and also the Middle East. From a finance perspective, that includes managing budgeting, finance, core finance teams, IT, procurement, and also the patient administration team, which looked after all the admissions for the patient journey, which we'll talk through shortly as well. Burnout from an administration perspective is absolutely top of the agenda of many CFOs and many leaders of the organization. And I'm very excited to be able to join you today to give you some insights and also from hearing about from the other panelists on also how we'll move forward with AI.
Fantastic. Thanks a lot, Nikesh. Your experience in the UK and Middle East is going to add a lot of value, especially, you coming from financial background. That's fantastic for this conversation today. So really appreciate your time today. May I request David to go next, please?
Hi, I'm David Martorano. I'm a psychiatrist. I've been a chief medical officer for a long time in behavioral health. However, I'm also, I like to think of myself as the authority on behavioral health and artificial intelligence. So in the whole scale of kind of what we're doing to change the delivery in behavioral health, both inpatient and outpatient, but physician burnout is a huge part of my day, not just physicians, nurse practitioners, how we're extending those roles, and also where AI will play a foundational role in kind of reformulating AI. I'm board certified in clinical informatics and healthcare administration, leadership, and management. I'm actually the only psychiatrist in the world who's attained all that. So I get to advise a lot of large behavioral health entities on how to address issues around both informatics and also leadership, which I really enjoy. So.
Fantastic, David. CMO, expert in AI, author. I think that's amazing. That's fantastic for our audience. We are really looking forward to hearing your insights today. Timothy, may I request you to go next, please?
Yes, hi, I'm Tim Poore. I'm the Chief Revenue Officer and co-founder for Post-Acute and Elder Care Platform. We're involved in we have a very unique point of view of the burnout issue, especially as it relates to AI. I have a decade of experience in working with health systems on transitioning complex patients and looking at the effects that has upon not only the care teams, but also on the patient journey. And so you may hear me mention the Mayo Clinic platform a number of times. We are a member of that as a qualified solution. And if you want to play at home, you can drink every time I say Mayo. That's quite all right. But very, very, very happy to be a part of this panel today.
Thank you. Fantastic. Thanks a lot, Timothy. And we have been chatting a lot in the last, few quarters or so. and it's always extremely beautiful to hear your insights. So thanks a lot for joining us today. Dr. Varman, please, introduction.
Hello, I'm Dr. Rahul Varman, one of co-founders of Syauctus AI, developing products that help address burnout in the healthcare workforce. I've prior worked with 5 large hospital systems, including Washington University, Texas Health Systems, University of North Carolina. I currently am affiliated with Common Spirit Health, which has over 25,000 clinical providers within it across 20 states, where I serve as chairman of the Clinical and Quality Improvement Committee there. And one of our main tasks and goals there too is to look at and study burnout in the clinical workforce, the costs of it, the causes of it, and how it can more deliberately be addressed and solved to both improve patient outcomes, but also improve outcomes for the actual providers and the quality of care they're providing.
Fantastic. Thanks a lot, Dr. Varman. And physician turned entrepreneur, founder. I think that's a fantastic profile. We are really looking forward to hearing from your insights. I see Bob is on the call. Bob, could you please quickly introduce yourself? You're on mute.
Can you hear me now?
Yes, please go ahead.
All right. So I'm sorry for being late. I had my schedule had the time wrong, but that's okay. I'm here. This is Bob Sweeney. I'm in the United States. I spend half my time in Memphis, where I live, and the other half in Los Angeles, where I live half the time. I spent most of my career in healthcare management and in buying and growing healthcare companies and taking them public and advising those organizations. My interest at this stage of my career is in advising young investors and young healthcare startups on the pitfalls of trying to accomplish what they're trying to do. And most of what my focus on with these clients has to do with assessing the customer audience, assessing the actual acceptability and usability of what they're trying to do, whether anybody will actually care about or use their service.
Fantastic. Thanks a lot, Bob. So we have Chief Financial Officer, we have Chief Revenue Officer, Chief Medical Officer, entrepreneur, investor on this conversation to share a lot of insights about new supervised AI agents that are going to transform the hospital ecosystem. Over the next 45 minutes, we will be hearing a lot of candid stories, hard-won lessons, real metrics, and practical advice that the hospital leaders can take into their organization and really transform their organizations. Now, let me start with the questions, and my very first question is to Timothy. So, Timothy, please talk about 2 or 3 administrative burdens driving clinician burnout in the hospital system today, and how much of that is related or tied to documentation, coding accuracy, or payer denials. Timothy, please.
Thank you. First, I want to kind of like just back up just a little bit to kind of set the setting on this. When it comes to burnout, you have to make sure everyone's like on the first of all on the same page, but also you have to care about your team and what their goals are. Otherwise, they're not going to care about what your I always put out as your little KPIs maybe. And if that isn't happening, there isn't going to be a very good transition or handoff on those things. Now, when we go look into like sort of like the data services and how AI can help, 20 years ago, and especially in our arena, we saw a lot of software as a service based platforms started to move in. Careport and NaviHealth were some of the more larger ones in our specific domain. And they were wonderful. They really helped bring health systems forward technological wise. And then there was the application of AI and sort of like these like small areas. And now we're starting to get into AI where it's much more systematic and overseeing. Because what we were seeing, some of the issues with burnout were the avoidable days. The delays that cause the patient staying longer, whether it be prior authorization delays or billing cycle delays or whatever it may be. The constant documentation, the repetitive documentation that clinicians have to do, it really takes them away from the work. And then if you have a decision tree, if you're working together in a care team and you're trying to get this patient down the road, and then you have to deal with denial management. And all of those areas are really, really challenging areas to address. And especially if you're working with a patient, you've taken an oath to help that patient, no matter what. Those denials kind of those pauses or areas really build up over time and cause more and more of this I'm just a hamster running on a hamster wheel and we're not making any actual progress, which leads to burnout.
Interesting. And Nikesh, would you agree with Timothy? Are you seeing similar kind of issues in the UK, in Saudi Arabia, Middle East, or you have different experiences as a CFO?
No, very similar. And I think absolutely echo what Timothy has just said. When we focus around the payor denials, the largest losses for any hospital relate to denials. And, some literature I've looked at, this can exceed over 20% of all claims submitted. I will talk a little bit more about claims in the next conversation. But, when you look at this, our payor groups are self-pay, fine. But then, the other payor groups are insurance companies and those who deal with international hospitals and have international patients. They'll have the embassies as well, all, with contract terms. So really links to the two big areas, coding, as Timothy mentioned, incorrect coding, and also poor documentation. And that puts an immense burden, not only on the administration team, but also the physicians. After the patient has been seen, we have to go back and forth. The revenue cycle teams have to spend an immense amount of time trying to work on submitting the claims. And you have CFOs pushing on timelines. However, I've noticed very lengthy timelines, and it can vary from the initial submission of claims being 3 to 6 months from when the patient has first been seen. That has to have a massive impact on cash flow. As we know, the patient's been seen, the costs are being paid, the revenue's being generated. However, we're not receiving the cash flow from sometimes 3, 6, 9 months later after the initial submissions. And I think the other burden that is happening is when we first submit all the claims, the denials, the submission that comes back from the payors, they have an initial denial rate. That can be 20, 30, 40%. That then takes another 3-6 months to try and resolve. A lot of frustrated people, a lot of frustrated admin people, a lot of frustrated physicians as well, all working together, trying to get the best out of what the payors can pay with. And they obviously have to have that information as well. So this has a very big burden overall. And, currently the rates I've looked at, even after the final denials, an organization generally has to accept about 5 to 10% of a write-off after the claims have been submitted as a final write-off within a timeline. That's significant when you realize the work has already been carried out by the organization. So that has a massive impact from a burden perspective, financially, naturally, from a motivational perspective, because everyone's done the work, and it has a big impact on our people and very importantly up to our patients as well. So I think there is a lot here, and we'll talk a bit more about how AI is going to really support us on this. But a huge amount of, I think Timothy used the word hamster wheel, people just going round and round on the same items again and again, becomes very frustrating. We have to follow the process. I think the payors will really take kindly to AI really supporting them and working in partnership with the hospitals as well.
Fantastic. Thanks a lot, Nikesh. And I think you share the similar feelings as Timothy. David, do you have clinicians or admin staff crying on your shoulder because of these denials or delays? Do you have those kind of situations?
So I would say that it's a complicated area in terms of what I frequently say about it is that we're asking doctors to wear two different hats, and we're asking them, instead of just to focus on patient care, to focus on how to document for revenue cycle enhancement, just to kind of use similar terminology here. And that is a huge burden, and it creates an adversarial role within the systems because doesn't become the companion of the physician. They become the representative of the payer within the organization, and it creates friction internally. I think that the inability to surface data and to guide physicians correctly towards creating the documentation that will be most helpful to the utilization review teams really creates a lot of that to begin with. We don't train doctors. I've been a professor for a long time. We don't train doctors for how to make money, which is a good thing a lot of the time. But that also is bad because you hire doctors within a hospital system inevitably to bring money in. And so when you look at those competing forces, we're not aligning purpose. I would say that I feel a little differently about the payers and their receptivity. A lot of payers have been using AI successfully to deny claims now for almost 7 years. And they've been doing it very effectively. The clinical side, we're really trailing in terms of catching up to what the payers are already doing to increase denials and to really force compliance in the teams with whatever their standards are.
Fantastic. So there's a huge problem, right? And AI got the right, right solution to solve that problem. And then in the next segment of the panel, we will be mostly talking about how AI is creating that bridge in solving those problem statements that our hospital groups or our clinicians are facing on day-to-day basis. And I would request Dr. Rahul to come in here, chime in here. So Dr. Rahul, where have you seen supervised clinician trained AI delivering the biggest efficiency gains without removing human judgment? And you may probably give examples in revenue cycle areas like clinical documentation improvement and denial prevention. Dr. Varman, please.
Sure. So a lot of great points. As Timothy mentioned, the delays or rework. When we've spoken with different providers or clinical systems, a lot of it has been founded initially on client discovery discussions or client discovery talks of what are their pain points. There's many pain points that AI has the potential to solve or optimize. There's different quotes such as up to 30% of a clinician working can be more on administrative tasks. Some other reports by the New England Journal of Medicine can say that clinicians can spend 2 to 1 time on administrative tasks versus talking with patients. And most people go into clinical medicine to do more of the clinical and patient-related chats and not necessarily all the ones that, as David mentioned, you're almost pushed to do more billing and optimization, which is part of how healthcare systems work. But things we've noticed, it really 3 things that are higher up that we hear more often. One is the clinical encounters and things can be a little bit chaotic. You're focusing on what the diagnosis and the care and the goals of care are, but you also do need in your head think, how do you bill it, et cetera. AI has been nice here with different systems and such as Augmedix or others that have created ways to capture details that have been discussed that are billable into an organized note form. Next is one way AI can help is prior to AI, a lot of it was reactive. As Nikesh mentioned, 20% of denials, 20% of claims can be denied. Other studies say that only less than 65% of denials don't get reworked. So 35% of them are the only ones that get submitted for rework and to get at this. And so one way AI can help is trying to predict it on the front end and not be reactive. So currently it's very reactive. Once it occurs, more work is put on the clinician's table. When I was working heavily in the clinical side, I may have seen a patient and submitted a claim, and 2 weeks later, I get a packet on my desk that says this was denied. And so I have to reframe my entire mind, go through the notes, go through the details, get a call from the insurance company. Sometimes that can be at 6 p.m., 6:30 p.m. when I'm already at dinner. And so you're not contextualized for it. So how can you save time by being more predictive rather than reactive? Next is prior to AI, you weren't always immediately seeing data and having clinicians learn so that they could improve in real time. By having more closed loop, rapid learning and data transparency, you can have clinicians see exactly what's being denied in organized forms so that not only is their number of denials decreasing because of being predictive, but you're also teaching them a little bit like, oh, this is what this specific insurance is commonly saying. Let me try to adjust that in future encounters. So those are probably the three biggest ones we've heard from clients and practices that it's been helpful immediately with the advances in AI.
Fantastic. Thanks a lot, Dr. Verman. And let me get the perspective from Timothy as well. Timothy, do you also feel that, as long as AI is predictive and doing the right interpretations, the problem is solved, or you see different kind of solutions, different kind of AI tools coming into the picture to solve this problem statement?
Yeah. So it was interesting, the relationship with AI and healthcare. Like during COVID, it was, we would talk to a hospital or a case manager or somebody like that, and they're like, pump this directly into my veins. And then after COVID, there was a period of time where there was a little bit more of a suspicion and apprehension regarding what AI can and can't do. Um, which is kind of, you know, like, I don't want to say naive or anything like that, but many health markets in the United States, there was concern about AI coming in to take their jobs. When the reality of it is that there's, name a department that isn't 20 or 30% understaffed in the hospital. And, so now, people are starting to come on saying, I really do need help. And I just want to be able to, supervise is doing a lot of heavy lifting here. But I would say more like a human in the loop is the term that we kind of like is used, is where the human can actually say, yeah, this is going along fine. Well, let's check on this. Or I don't agree with this. And then it goes back into the AI model, and the AI model learns to correct from that. And those are the type of tools that we're seeing develop. Part of the Mayo Clinic platform, go ahead and drink. We're seeing several other companies along those lines where they're doing more of a human in the loop, where the human, their expertise is allowed to critique and amend what the AI output is.
Interesting. And the possibilities are endless, right? There could be more solutions, more AI solutions dealing with different kind of regulatory frameworks, dealing with different kind of clinician burnout challenges in different parts of the world. But so we have established the problem statement. It is pretty global. It is massive. And obviously, clinicians are not trained to do the admin work. We understand that, yes, AI can solve this problem statement right away with the right kind of thought processes, with the right kind of, the algorithms and so on and so forth. Now, the question is, what is the real ROI impact? What are the KPIs that hospital leaders can really achieve out of these supervised AI solutions? So I would request Nikesh to share probably a few concrete examples where AI really helps scale revenue or reduce avoidable losses. And also please talk about the timeline, the measurable impact on denials or on underpayments. Nikesh, please.
Thank you, Dr. So I'm going to pass over to Rahul in a moment, who's going to talk about solutions that have happened and some examples there. But let me just take a step back in terms of Pankaj, to just remind everyone the burdens that are faced by the organizations on the patient journey, because this has to be all around the patient as well, of how we can improve our patient flow and our patient journey for the organizations to see more patients in a streamlined manner, which as a CFO then relates to revenue as well. So when we look at the patient journey, there are a number of areas which the RCM team play a very manual part, really, really manual work that they have to do, all very happily doing it. And that causes a lot of undue pressure for both the admin and the clinical teams as well. But it's all directly linked to revenue. So if I take a step back, let me just take it step by step here. So when a patient first looks at coming to a hospital, they may contact the contact center, who are then under pressure to do the eligibility checks. If that is or is not done swiftly, the patient has a choice to go somewhere else. So you've lost revenue there. Then you get onto, they want to make a booking. So they try to make a booking. They have to schedule, is a physician available one day, next week, next following week, week after? Again, loss of revenue potentially. Speed is of the essence here. Obtaining pre-authorization, I think one of my colleagues just mentioned this before. obtaining pre-authorization, great, straightforward, but there could be a number of rejections as well for a number of reasons. So the rejection, before we even get to denials, that patient is rejected when they know they're eligible to come to the hospital. So that causes frustration, and that means that patient can go, once again, they have a choice of where to go, they can go to another hospital. So another aspect of losing revenue. Once they've got an appointment, they happily come in. Now, before they even come in, there is generally industry norm around 20% is a no-show rate that I've seen throughout not only my organization, but throughout healthcare. So 20% of no-shows globally, that's a significant amount. That's 1 in 5 of your patients not turning up. And actually that means that's 1 in 5 of you've had lost revenue there, where you've already hired the staff, you've already got nurses there, physicians there, clinic time is utilized as well. So that's already lost revenue for the organization. Potentially, then we have a follow-up of appointments, booking the diagnostics. The speed to booking is very important, particularly when you look at the private healthcare area as well. Speed for booking is very key, and accessibility. Get to admissions, and you get to the final bit around charging, billing, and then the claims. So when you look overall, that journey has to be really, really smooth. And the quicker we get into the AI model around some of those administrative tasks, will be better for the patient who's coming into the organization and the hospital. Leakage in revenue is also another big area as well, and that accounts for about 6 to 10% of revenue generally in hospitals, and that relates to unbilled services. So you hear many times CFOs say things haven't been charged, whether it's consumables, whether it's time, whether it's procedures, haven't been fully charged. That's a very manual process. That documentation is looked at and then cross-checked to the billing itself, and that's where AI will play a big part in cross-checking that, so making sure that it's not overcharged, all the appropriate items have been charged as well. Underpayments, have we collected co-payments? Have we made sure that the underpayments that, not a denial, but generally there are just general underpayments on some invoices. Contract compliance is also very key as well. So I think when, Rahul mentioned 65% of claims or 35% of denials aren't necessarily reviewed again. Actually, many times contracts are signed, they're not then rechecked. So after the contract is in place, many times the contract's in place, but if we're underpaid on those contracts, we won't know that on a day-to-day basis. So that's really key as well. And last bit is documentation gaps. So I think there's a number of areas where we see opportunity around growing revenue and also around increasing the efficiencies that we have in the organization. I think, Dr. Rahul, you're going to mention some solutions there as well.
Yes, so across each of these spectrums that you mentioned, Nikesh, different solutions have come out that have been providing good value. Typically, providers have a term for it now with the evolution of medicine and more administrative. Some of them call it pajama time, meaning after they finish their work, they go home and they're sitting at their dining table doing more work, which is all this administrative work. On average, many report 1 to 2 hours per day they may go home and do extra work. If you're a surgeon, you may not have as many clinical notes, so maybe 2-3 days out of the week. If you see patients in clinic every day, 5 days, it may be 5 times that 2 hours, so up to 10 hours that you're spending extra additional work. And so that's a big thing for providers contributing to burnout, decreasing that pajama time. Things such as Scribe AI, Augmedix, where when a provider is talking to a patient, it's capturing all details, automatically putting it into the correct section, knowing smartly what are billable components and putting it there so that when they're finished with the clinic and they look at their notes, it's all pre-populated. They're not having to go from memory and redictate and recalibrate like, oh, what was the exam? What did I miss here? Because often patients are stacked back to back in neighboring rooms. So that's a huge thing, which is saving time in them. Next is accuracy. One of the problems is billers may just have finished school and joining a clinic. There's no guarantee that you're getting a high-level biller. But with AI, one of the things is you can train all AI models based off the most accurate billers, so it gets smarter with time. And so when we test models that do billing solutions such as Billing Assist, et cetera, we find that compared to an expert biller, it is almost a 90% accuracy with what they're delivering. When you're looking at providers and how are they billing it, are they underbilling it? Let's say they saw a clinical patient but didn't discuss which side the lesion was on or didn't document something that was in a primary care note that the patient also has Alzheimer's that makes it a more complex note and it was a more complex visit, it automatically pulls some of those because it did make your visit difficult, but you may have just been focusing on the diagnosis, which was knee pain, even though those other comorbidities do contribute to a more complicated visit. So we find that it increases the optimal capture of the complexity of your one without you having to think of all these net of things that are occurring, and you can just focus on the diagnosis. Denial rate, as Nikesh mentioned, can sit around 20%. Providers don't go into rooms thinking, oh, this insurance requires this. This insurance requires that I document Flonase. This insurance requires that I do this. That's a lot of burden to think of every patient what it is. And so what some different solutions such as Appeal AI or other solutions that exist can do is look at auto pull what insurances require for that patient, because that's usually linked, and either cue the provider that, hey, this detail was missed, ask the patient while they're still here, or ask your nurse to give it a call, so that it's taking that 20% denial rate from 20, and we're finding that it's taking it less than 10%, so almost a 50% reduction. And with time, the goal is, can we catch up to the levels that insurance companies, as David mentioned, are using AI to arbitrarily deny claims? Can we catch up to those rates so that it's not extra burden on providers, but instead it's AI automatically filtering those and fixing that? We found with discussions with different providers that some of them, I mentioned I do it often at home after 6 o'clock. We found that some providers block off half a day of their week, so maybe a Friday afternoon, just for getting on calls with insurance companies because they don't want to take it home. So that's half a day of non-productivity of just having phone calls to try to get reimbursed for work they had already performed. And so that's a claim rework time decrease up to half a week, half a day per week. Now, from a finance perspective, as Nikesh had mentioned, net collections, we do see that there's an increase in net collections. And the nice thing about this is an increase in net collections without increasing extra volume of workload. It's simply finding all these little gaps that are existing, from denials to details that are being missed, et cetera, to increase it. Because that is, at the end of the day, hospital systems do meet and get consultants and ask them, hey, how can we increase our net collections? And this is a much more humanistic and provider-centered method, instead of saying, hey, every provider needs to see 5 new patients per month if they're not meeting goals of how much they're collecting. That is what ends up driving a lot of providers to leave hospital systems. So that's some different outcomes we've been seeing that AI has been helping to address burnout.
So from Nikesh and Dr. Rahul's perspective, if I got it right, even if hospitals just adopt some of these AI solutions and fix these, issues at the moment, they don't have to pay millions of dollars to the consulting firm. They can still increase their revenues by 20-25% very easily by just fixing these issues with the billing, with the unbilled services, with the denials, with the missed appointments and things of that nature, which is fantastic. Now I'll have to jump and get feedback from David on implementation strategies and challenges, because whenever you integrate something with the hospital systems, it's not easy. There could be concerns around data privacy, concerns around regulatory framework, adoption, and a bunch of other things, right? So David, from your perspective, what are the lessons that you have learned? What are the strategies that you have deployed while implementing these kind of interesting and innovative solutions into the hospital ecosystem, please?
So it's really amazing what a spectrum of response there is to AI. I use different AI tools with patients all the time, and the patients are very receptive to it. I would say that provider receptivity, a lot of the things that were brought up earlier about kind of the fear that Timothy was talking about a bit, that it's going to replace your job or make your job less interesting, is a widespread concern that requires education, because it should make your job more interesting. Again, I mentioned that surfacing data. The quicker you can surface data for clinicians and allow them to make the best choices for their patients, that human in the loop that Timothy was talking about as well, the sooner that you can really get people to recognize, wow, my work is more valuable. The other thing that I think is really important is understanding workflows in general. You have to look at the workflows, not just of your clinical team, but the end-to-end workflow of your organization. Whether you're an outpatient or a hospital-based organization, you have to look at, why do we do the work we do? Where can AI facilitate that work? And what does the work look like under the best possible circumstances with AI? A lot of times a single point solution is attractive because it's easy to implement, but it may lock you more into the processes that are going to be a challenge down the road. And so I think it's very important that when you're looking at all of this, you're thinking about, what does this mean, not just for this revenue cycle, but a few revenue cycles ahead? Is this going to maximally reduce costs? And then how does this make everybody who's contributing's work more meaningful and valuable to them? Because when you talk about burnout, get back to the origin of the discussion, one of the most kind of telling areas of burnout is a lack of meaning in one's work, especially when you're talking about highly educated people. When you ask them to do work that they perceive as having low value or low meaning, that work is always it always has a very negative impact on the perception of what they're doing. And it's often very hard for people to connect fighting denials with helping patients. And so doing that work up front and educating people about, you actually are helping the patient, because the patient needs the help. And if they don't get it covered, the service may not be available to them, or they may be responsible for a larger portion. You know, Nikesh was also talking about how the leakage because of not being able to get copays. When you reduce the amount of the copay because you were effective in the submission of the claim, that can really help the patient in the long run. And when you're educating your entire team about how this is actually helping your patients, because financial stress really is a terrible thing, and medical debt feels like a huge weight on a family or a person's chest when they come out and they get a massive bill for a procedure they absolutely needed. But if we'd been more effective at managing that early on and figuring out what would be covered and what would not be covered, I think we can really help our patients more and our teams more.
Fantastic. So education and really letting them know that, hey, you will find more meaning in your work if you adopt these new age AI solutions. Thanks a lot, David. Timothy, please.
Yeah, so with the integration issue, you know one health system, you know one health system. It doesn't really translate from health system to health system because we mentioned earlier, these EHRs weren't really built for these types of platforms that we're seeing now. And this becomes a very big challenge now for your chief medical information officer, your chief financial officer on managing this, and what do we do next steps. So we sort of cheated a little bit and go ahead and drink. So we partnered with a major health system, MCP, and there you go. And because they have that back-end integration where we can go directly into Epic, Cerner, Meditech. Now it doesn't completely solve all the problems because there'll still have to be a buy-in from the hospital, but at least we have that where we say, okay, we're not going to take that demand off of your IT, and we can understand and integrate with your workflows much easier that way. Right, because you don't want to have to introduce a new system and then say, oh, by the way you were doing admissions before, we need you to do it a different way now. Well, the thing is, that hospital, they were doing it that way for a reason, right? The other ways, maybe they didn't work for them, right? Maybe there wasn't consistency. Maybe they weren't implementing, or uptake wasn't going as evenly. Maybe the patient population, the SVI, the social vulnerability index is too high, and they can't, and it weighs down all the rest of their information, right? And so those are other factors that have to be played in. So you have to be able to, when you're integrating, you have to be able to integrate in a way that's not going to disrupt the workflow. Additionally, it's the observer effect, right? When you integrate into the system and you were training your model on what the outcomes were, or what the prediction model is going to be, and now you're saying for them to change their workflows. Well, now you have an observer effect that's taken place, and your models aren't going to match as well.
Thanks a lot, David and Timothy, for sharing your insights on the implementation strategy. And I would love to hear it from Nikesh as well, because Nikesh, I'm sure that the regulatory framework is very different in UK and in Middle East, right? Are you seeing similar kind of challenges with the implementation? What are your learnings and strategies that you have deployed with your other C-suite leaders?
Yeah, so thank you. I think the biggest piece for me is around when you look at implementation of any system or any tools that you're providing to the teams, there's naturally a tendency, I think it's been alluded to before, people are going to be afraid whether it's going to, are they going to lose their job from it? How's it going to impact their job as well? So I put it into three buckets, three types of people when you're looking at change. And we've done a number of ERP implementations, very similar we're going to do with AI as well. So you're going to get those who are going to be all for the change, all happy, all going to be very progressive. Those who are going to be indifferent really don't know either way, so they will just stay quiet. And those who will be resisting the change because they've been so used to doing something, or how will it impact their job, et cetera, et cetera. And I think the learnings for me is really how do you, sort of enhancing what my colleagues have said, really looking at three things in particular, looking at communication, having regular communication is absolutely essential for the wider organization, for the core team. And within that communication, having a very clear plan, who's going to deliver what, when, how, having a regular check-ins, and also having an escalation process as well. So you don't want to delay things when we've got an exciting timeline, very tight timeline, and everyone's excited by it. So keeping it really lean and mean, but really having a proper process in place to try and have delivery. So that's one. Second part is having engagement. We don't want we don't want our employees to feel this has been done to them. We want them to be engaged, that we're working together. Actually, as we've said before, we're providing tools to the organization to help the employees of all, whether they're admin or whether they're clinical staff, which will then in turn help our patients. So these are looking at tools, how we can look for the future. And third part is accountability, being very clear who's going to be delivering what, when, and how, and making sure they're accountable so people feel ownership as they move forward with this enormous change program that we'll be looking at.
Fantastic. So again, it's very important for the admin staff and clinicians to think that we all are aligned. The education is extremely important. They need to understand that these AI solutions are their friends. They're going to help them in the long run in saving time, in doing more meaningful work, and bring more revenue for the hospital. Fantastic, and it's good to see that the kind of strategies that are working in the US will also be working in the UK and Middle East. So thanks a lot, all the panelists, for sharing your insights on this specific question. Now let's talk about the future. So we have adopted solution, but how do we scale to achieve a huge breakthrough? Think about 24, 36 months down the line. How do you see these supervised AI solutions evolving from just simple efficiency tool to strategic revenue and care differentiator? And if you are talking to a C-suite leader who may be sitting on the fence, thinking whether this is the right solution for my hospital or not, what would you say them? What would you tell them that, hey, you should definitely adopt this? What will be your advice to them? And I would request David to go first. David, please.
Okay. So I think that when we look at the future, there's a few different factors that are really coming into this. We're seeing huge layoffs right across the tech industry in engineering. And the reason for that is AI-based coding. The exponential growth in tools like Claude Code really are having a massive impact on what solutions are going to be coming to market. And it's why I say that looking long-term, you want to understand how a platform is adapting for AI. Whatever platform you're going to be working in, the simple modular solutions aren't your long-term path. because the ability to code quickly and build meaningful solutions exists now for everything. And so what you want is one that's really going to, as Nikesh was saying, although I think we see it slightly differently, but the idea of changing workflows being a big part of it in the long run, because we're going to have to learn to work with artificial intelligence. And it isn't just a tool, it's the first thing to ever have real agency. And as it continues to evolve and as it becomes truly agentic, and we're not just talking about fake agency where it does a small task, but as these agentic roles grow, you have to be able to think about what does that mean in a healthcare environment, and what does that mean in a business environment, and how do those forces align correctly through well thought out architecture, and then working with your partners to build that architecture at a real domain focused level and not at a specific task focused level.
Fantastic. Thanks a lot, David. I was drinking my water and you.
I was just gonna. I can talk all day. I didn't want to. I didn't want to go forever.
So that's the passion.
Kind of.
See, that's the beauty. This is the passion that you have about improving the hospital systems. And I know that you can keep talking about this topic for hours and hours. But let me bring Dr. Rahul into the picture again. Dr. Rahul, what do you think? How the future will look like?
Sure. Absolutely agree with David that it's with a lot of tasks, AI will be having to be very involved, and the best approach will be really having agentic type solutions that are taking a lot of all these type of things that are difficult or anything cumbersome and putting it there and really allowing humans to have that humanistic focus when they're dealing with the patients. A good quote I had heard too was, medicine evolves at the speed of trust. And so a portion of that really is, what are the small wedges that are going to add value to clinicians that is going to provide great value early on in specific ways and build slowly based off of those. And then when I look 10 years, 15 years down the road, like David mentioned, there probably will be a complete rug pull, and the entire architecture, the current EMRs we have, such as Epic, etc., may be completely built from an AI standpoint that it's really able to integrate and capture everything in all details a lot better. And building up to that is going to require very trustable small models that are doing it. One way our team approaches it with solutions such as MetaNote, Billing Assist, Appeal AI, is whenever working with a clinic or a hospital, really sitting with them and doing a retrospective review of, hey, what have been your metrics, et cetera, to date, and comparing it with everything as a bell curve that's quantitative. Where do you sit on that bell curve? And then sitting with them and saying, which of these metrics would you love to optimize and see adding value to your clinicians? So anybody sitting on a fence, one thing is, when you're talking to any solution or any group, can we define a time point, whether it's 60 days, 90 days, and specific outcomes we want to look at with those, instead of bringing it into a clinic saying, hey, let's bring this in, but not have any specific outcomes and things we're looking at. A lot of the academic and other big centers we've worked with, we approach it almost as if it's a research study that's going to be published. Let's have a specific methodology, specific outcomes that'll be defined. Next thing is, when you are looking at solutions now, you can make, as David said, with different coding solutions, et cetera, coming out with AI, there can be so many things produced that are very complex, convoluted. One thing to always look at in the front end is demonstrations of the products that the providers are going to have the least extra things added on with the AI solutions. Is it the fewest clicks they could do that gets the objective done? And to have this be delivered in a good way is really going to require, as Timothy mentioned, humans in the loop, specifically providers in the loop, so that they give their feedback of, hey, what exactly is the medical workflow and how would I like it improved? Because sometimes if it comes purely from a technology standpoint, you get a great complex solution, but is not going to be able to be used from a healthcare perspective in an efficient, streamlined way. So those are some different pearls for implementation and where the future may go.
Fantastic, fantastic. Thanks a lot, Dr. Varman. Timothy, please.
Yes, I agree with everything that's been said before. I would add that the number one cost savings benefit for health systems and for patients involved is quality. And as these systems are evolving, if I'm a CFO or a Chief Medical Information Officer, I'm looking to the future in which we are shedding ourselves of some of the prior structures in which data was organized within our systems. And we're going into systems that are much more network and much more of an orchestrative type of AI platform in which they're able to provide that additional lift through human in the loop, much more than what we've seen in the past. I'm going more towards that. AI tools that build efficiency are great, but as long as we're building that efficiency so that we can have this more of this orchestration of care for the patient, is the direction we want to go. Right.
Fantastic. Nikesh, if you are talking to your CFO friends in the hospital groups, probably a dozen of them, what advice would you give it to them?
I think the advice I would give them is actually remain focused and take the lessons learned from other implementations that you've done. As we always seem to start again. I think that's just human nature. Let's start everything again. If we've got lessons learned, and there's the expression of, best practices, you could take that from somewhere else. So take the lessons learned. All my CFO colleagues, friends, have all implemented ERP or some system or another. Let's take the lessons learned from there, because I think it's going to be really essential using that and then moving forward with it. AI is fast becoming business as usual in many organizations. We've now moved from the experimental stage. We're now making this part of our normal life. And I think from a financial perspective, I see, you mentioned, Pankaj, 12 to 24 months. I'm already thinking way ahead, but I see the next 12 to 24 months as really laying down the foundation now. Particularly, I'm talking from the finance side, not the clinical side, but laying down the foundation. This will help in turn increase revenues. This will help in turn reduce loss, and it will help automate the revenue cycle tasks, which will prevent revenue leakage as well. And all of this in time will generate millions for organizations, which will keep all of your CFOs, including myself, very happy as we progress, capturing revenues and reducing inefficiencies. Also, I just wanted to touch, AI will also help around faster financial data. I know we haven't touched on that today, but financial data, data that's going to be very important when we're looking at forecasting, when we're looking at cash flows, we're looking at budgets. So all of that's going to be really essential, rather than having to work excessive hours trying to do that and not really looking at the data because we're too busy producing it. This is where we'll be able to really look at the value behind the data. So most importantly for me, my message to my CFO colleagues, this will help reduce the burnout of staff within the organization. The staff, our employees, are our biggest asset in any organization. So if we look after our asset, we'll start seeing increasing patient numbers, efficiencies, and revenue. And secondly, this will drive a very, very smooth journey overall for our patients. And that's what we're all in healthcare for as well.
Fantastic. Thanks a lot, Nikesh. That's a very impressive appeal to the CFO colleagues. So thanks a lot for that. And we have extremely seasoned healthcare investor, Bob Sweeney, sitting in the room with us. He has been patiently listening to all the insights. Bob, I would request you to share your insights on how do you see supervised AI agents evolving in the next couple of years and helping hospital systems. Bob, please.
All right, can everybody hear me okay?
Yes, please go ahead.
Sure. So I don't think you can be on the fence about AI any more than you can be on the fence about the. I mean, if you're on the fence, then you're missing the story. So, my position, in contradistinction to what many of the other panelists do, is I'm on the other side of the table. I'm looking at innovations. I direct due diligence for the healthcare fund in which I'm a principal. So I'm looking at innovations that might come into this space, and I'm looking at the difficulties and problems involved in using them. Every healthcare system I know about has a great deal of inertia in it. There are legacy ways of doing things. There are conflicting agendas. The decision-making process is not one imperial source. There's a multiple to this environment. What I share with my C-suite colleagues all the time, keeping in mind that most of my C-suite colleagues are on the medical group side or the delivery side as opposed to the implementation side in the hospital. But I would suggest to the institutions that they become more involved with the due diligence process for reviewing products.
Right.
They can do that. I don't care if the product's being brought in or proposed by a medical group or an individual physician or being proposed by Philips or some huge company like that. Just because a big company recommends a solution doesn't mean they really understand how the thing will be implemented or used by providers. And what providers do at the end of the day influences the experience of your patients. And therefore, it's important to understand what motivates them. I think the other thing, other than being involved in due diligence, I'd recommend is appreciate, and some of you have implied this, the inherent structural conflicts of interest between the different institutional players in space, hospitals, pharmaceutical companies, device companies, the government. Each of these organizations or entities, if you want to call it that, has a different outcome. They're not conjoined at the hip somehow. So, for example, recently I spent some time looking at data analysis in a well-known pharmaceutical company in the United States that, and I determined after a long discussion with their data analytic people that their goal is to optimize the combination of deductibles and copays, even with generic medications, in order to optimize their financial return. Well, that isn't necessarily in the interest of the patient or the provider, and it can create, a great deal of extra work for people in these organizations trying to sort out what's going on. If you're an individual, it's hopeless to try to discuss with a pharmaceutical company why they changed the tier level for your medication when it's a generic from level 2 to level 4. That means you or the provider's organization has to devote their time to try to sort that out in order to address the patient's real concern. So, summing it up, become more involved in the due diligence review process for the actual solutions being proposed. And secondly, appreciate and try to understand and be able to explain, even if you can't change it, the conflicting financial and organizational goals and outcomes for the various entities that are involved in providing healthcare in this country.
Fantastic. Thanks a lot, Bob. I think you shared some really interesting insights from different perspectives, which is quite valuable. And again, as David was mentioning earlier, probably this is a topic on which we can keep talking for hours and hours. But yeah, we spent 1 hour together discussing this really interesting topic on how to improve revenue for hospitals through different kind of supervised AI agents, how to reduce the burnout for clinicians and give them more meaningful work that they may appreciate, they may like. Again, I really appreciate the time and insights today shared by all the esteemed panelists from different parts of the world, from different experiences. So that's really, really appreciated. And I'm sure that we will have more such sessions later on to figure out how we can collaborate with each other, how we can support each other, and probably how we can make the overall healthcare hospital system extremely exciting, innovative, and with a lot of efficiency. So again, thanks a lot, everybody, for your time today. It has been fantastic time today with you, and let's reconnect soon. Thank you very much. Thank you. Bye. Take care.
Bye, everyone.
Bye.
Bye.